Thank you for the introduction. Good afternoon, everyone. Since I'm the last speaker, I will keep it short so we can enjoy dinner soon. At Samsung Medical Center, Professor Jaewon Jo and Saku Lee started the liver transplant program, and Professor Kapsu Kim, our transplant anesthesiologist, has been with him from the beginning. Even back when the risk of transfusion was less emphasized, our surgical and anesthesiology teams worked closely together to reduce the need for blood transfusions. Over the years, by improving surgical techniques and using intraoperative cell salvage and autotransfusion, we could have significantly reduced our reliance on transfusions. I'm proud to be part of this team, and it's a pleasure to work with such dedicated surgeons as an anesthesiologist. My name is Kwon, and today I will be talking about various strategies to minimize peri-operative transfusion, especially in liver transplantation. The page. Okay. Let's start with this quick quiz. This chart shows various potential complications that can occur after surgery. Now, can anyone guess what this big red section means? Was it too easy? The answer is transfusion. I'm sorry. This chart is based on data from the American College of Surgeons, highlighting the frequency of complications following surgery. You can see that transfusion is a significant issue comparable to major complications like infection, stroke, or myocardial infarction. It's now recognized as a major adverse event during surgery. This shows us that transfusion is increasingly seen as a critical event that can occur during the perioperative period. For over 40 years, experts have been suggesting that we need to change how we approach transfusions, and many studies have supported this idea. But honestly, it didn't get much attention from those working in the medical field. That changed in 2015 when Nature published a groundbreaking article with the headline, Save Blood, Save Lives. The article explained that reducing transfusions can actually improve patient outcomes and save lives. The article even called transfusions one of the most overused treatments in modern medicine. In response to this shift, there has been a significant increase in research on bloodless surgery and blood conservation strategies. And when it comes to transfusion, we cannot overlook patient blood management, also known as PBM. After years of research, the World Health Organization started recommending PBM in clinical practice back in 2010. Now there's a global push for the urgent adoption of PBM, with many encouraging widespread participation. PBM is all about preserving as much of the patient's own blood as possible and minimizing the need for allogeneic blood transfusion to improve patient outcomes. There are the three pillars of PBM, which can be applied to the liver transplant patients. It's quite complicated and difficult to read. So today, I will break down these concepts into three main areas simply. A for anemia, B for bleeding, and C for coagulopathy. I hope this helps us rethink how we can apply these strategies in liver transplantation to further reduce perioperative transfusions. This is my disclosure, and most of these are actually related to transfusion and liver transplantation. So let's get started. Let's start by talking about anemia. In non-emergency surgeries, it's so important to correct anemia. The surgery is often delayed if a patient is anemic. Anemia after surgery is also a significant issue for liver transplant patients. There are some options for correcting anemia. While transfusion is a straightforward way to increase hemoglobin levels, it's important to treat anemia based on its underlying causes. The most common cause of preoperative anemia is iron deficiency, and this applies even to patients with end-stage liver disease who are awaiting a liver transplantation. Post-liver transplant anemia is also a concern which are common in these patients. About one-third of patients with post-transplant anemia exhibit lab characteristics of iron deficiency anemia, and 25% have deficiency in vitamin B12 or folic acid. Post-op anemia is known to be linked to long-term mortality and graft failure. Research, including Professor Sponge's study in the Lancet and the recent initial trial, has shown that using intravenous iron before and after surgery can reduce the need for blood transfusion. However, there are not clear guidelines for treating iron deficiency in patients undergoing liver transplantation. The liver is key in iron storage and metabolism, and many of these patients already have iron accumulation in their liver. This raises concerns that giving intravenous iron could lead to iron overload and potentially worsen liver function. That's why most intravenous iron supplements come with warning for patients with liver disease. So, while treating iron deficiency in these patients is important, and we still face challenges due to the lack of strong evidence on the safety of iron therapy in those with end-stage liver disease. So our team conducted an animal study and published the findings. We found that intravenous iron, even at higher doses, did not worsen the degree of liver fibrosis. Additionally, there were no significant difference in liver function or portal vein pressure, leading us to conclude that intravenous iron supplementation may not negatively impact liver function or exacerbate cirrhosis. However, further clinical study is needed to ensure the safe use of intravenous iron in patients with liver disease. Lastly, let's talk about transfusion threshold. The TRIX trial and other studies show that these thresholds are gradually being lowered across various surgeries. While massive transfusions are necessary for uncontrolled bleeding, a restrictive transfusion strategy is generally recommended even in liver transplantation. At our hospital, we aim to intraoperative hemoglobin threshold of 8 or lower, though we may use autologous blood at higher levels. For platelets, we transfuse only if the count is below 30,000 and there is active bleeding. Postoperatively, hemoglobin level of 8 or even 7 is often acceptable. Therefore, it's essential to perform thorough anemia workup before and after surgery. Treatment should target underlying issues like iron, folate, or vitamin B12 deficiency to reduce mortality and morbidity. Even liver transplants, restrictive transfusion strategies should be considered. Next, I will talk about blood loss. Thanks to advancement in surgical techniques, the need for transfusion has significantly decreased over time. At our center, our distinguished surgeons have successfully performed 100% pure laparoscopic living donor hepatectomy, even in case with complex anatomical variations. More recently, we've also started using laparoscopic and robotic techniques for liver transplant recipients. Multiple studies show that minimally invasive study can reduce the need for blood transfusion, making it a valuable approach in liver transplantation. Using hemostatic agent during surgery is also crucial for reducing bleeding. As shown in the picture, applying local hemostatic agents can effectively minimize bleeding without systemic exposure. Since many of you are already know much about this, so I will move on to the next point. When local hemostatic agents are not sufficient, systemic hemostatic agents are used. In liver transplantation, fibrinolysis can occur during the late unhepatic stage and after reperfusion due to TPA released from vessels not being cleared by the liver. Antifibrinolytics like tranexamic acid are effective in reducing blood loss and the need for RBC and FFP transfusions. In liver transplantation, there is a lack of hepatic artery thrombosis, so the use of tranexamic acid needs a careful approach, ideally guided by viscoelastic testing. And as an anesthesiologist myself, one of the best ways to reduce blood transfusion during surgery is by using a cell saver for auto transfusion. At our hospital, we routinely use the cell saver for all liver transplant patients, including those with hepatocellular carcinoma. The process is simple. First, blood is collected from the surgical site, then it's washed and concentrated before being returned to the patients. In our center, during the collection period, surgeons always help us by squeezing blood out from gauges and use cell saver suction to minimize blood loss. This salvaged blood is centrifuged and washed to produce concentrated RBCs with a hematocrit level of approximately 60 to 70%. The concentrated blood contained through the cell saver contains not only RBCs but also other cellular components like leukocytes and in cancer patients, even cancer cells. Consequently, concerns have been raised about these other cellular components. Specifically, there are worries about the potential reinfusion of viable cancer cells into patients, which may increase the risk of cancer recurrence. These complications can be particularly dangerous for immunocompromised oncologic patients, such as liver transplant patients. So, there have been many efforts to address this concern. Among methods to avoid reintroducing the other components of shed blood, the leukocyte depletion filter is widely used. If you look at the picture on the bottom right, you can see these various cells attached to the fibers inside the filter. This filter not only removed leukocytes, but also cancer cells. This study also suggests that a leukocyte filter can remove cancer cells from salvaged blood. However, as this evidence is from a preclinical study, clinical research is needed to confirm the safety of using a leukocyte filter to remove circulating cancer cells in various surgical settings. There are only a limited number of studies evaluating the safety of salvaged RBC reinfusion in HCC patients. Moreover, those studies were experimental. So our team conducted a study from liver transplant patients. In patients with hepatocellular carcinoma undergoing liver transplantation, it was found that patients who received autologous transfusion did not have an increased risk of cancer recurrence after transplantation when compared to patients who did not receive autologous transfusion. This is another study we published. Our team conducted a further study in patients with advanced liver cancer, and these patients are assumed to be more likely to develop metastasis and recurrence. If you look at the left side of the slide, you will see the graph of the overall recurrence. Similar to our previous study, autologous transfusion did not significantly increase the risk of cancer recurrence after transplantation when single leukocyte reduction was performed before reinfusion. Interestingly, in both two studies, autologous blood transfusion was associated with a lower risk of cancer recurrence. If you look at the slide, one of the French editorials were actually talking very positively about our research. Based on evidence I mentioned, our institution is routinely using cell saver with leukocyte depletion filter in liver transplant patients with HCC. To find out the reason of more favorable outcomes for autotransfusion, our team are conducting experimental studies with the natural killer cell research team of our hospital. Plus, here's a recently developed device that salvages not only RBCs but also platelets for autotransfusion. This could be especially useful for liver transplant patients where platelet transfusion can sometimes lead to negative outcomes. While it may be seem very minor compared to other aspects, reducing blood loss from sampling is also important. Using inline blood sampling device can help maintain the same quality of care while reducing blood waste. Additionally, using smaller tubes and enhancing staff training can further reduce blood loss associated with sampling. Lastly, I will discuss coagulopathy. Patients with advanced liver disease have a delicate balance in their blood clotting system. They often have lower platelet counts and fewer clotting factors, but this is balanced by other changes like decreased protein C and higher levels of certain factors like bone rebrand factor or factor VIII. This balance is very fragile and can be easily disrupted by things like invasive procedure or changes in blood volume during surgery. You can think of it like walking a tightrope over a river where any slight disturbance could lead to either bleeding or clotting complications. It's a situation that require many careful management to keep things stable. Patients with cirrhosis often have abnormal clotting tests like low platelet and high INR, but these don't always mean there is a higher risk of bleeding due to these rebalances hemostasis. To maintaining this, many transplant centers use viscoelastic tests during liver transplants. Studies show that the help reduce the need for blood transfusions, especially fresh frozen plasma compared to standard lab tests. Depending on the test result, fibrinogen concentrate or other factors concentrate may be used. However, the availability for fibrogen concentrate is limited in Korea, making it difficult to implement these strategies. This slide presents an evidence-based algorithm for rotem-guided bleeding management in adult liver transplantation. Because of time, I will skip these details, but you can find in this review article. Lastly, I want to emphasize that maintaining normal body temperature during liver transplantation is essential for effective blood clotting. Hypothermia can disrupt this process by impairing the enzyme needed for coagulation, leading to increased bleeding risk. As soon as anesthesia begins, the patient's body temperature can drop rapidly. Therefore, it's crucial to use a forced air warming system to maintain the patient's temperature throughout the surgery. As you can see from the image, these systems are designed for various surgical procedures, including abdominal surgery, making them easy to implement during operations. Additionally, when administering fluid or blood, it's crucial to warm them up and avoid any drop in body temperature, ensuring smooth coagulation and reducing the risk of bleeding. To sum up, it's crucial to conduct thorough anemia workups both before and after surgery. Treatment should address the underlying causes like iron deficiency or vitamin B12 or folate deficiency instead of transfusion. Also, a restrictive transfusion strategy should be considered. Minimally invasive surgery has been shown to reduce the need for blood transfusions. During surgery, using intraoperative blood salvage and autotransfusion, even for cancer patients, can be safe after leukoreduction. Finally, platelet transfusion should be limited in case of active bleeding. Coagulation management is best supported by viscoelastic testing, and maintaining normal body temperature is also very important. You probably remember the slide I showed at the beginning of this presentation. I hope strategies we covered today have made it clear how we can reduce transfusions. Let me close with something from a talk that really stayed with me. Transfusion is a lot like transplantation. The blood we transfuse may seem like any other fluid, but even one unit can greatly affect a patient's prognosis. This is why we need to be very careful when deciding to transfuse in clinical practice. Finally, I want to sincerely thank the surgeons who work with us on this journey to reduce transfusions. Thank you for listening to my presentation. If you have any questions, feel free to ask. Thank you so much.